Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. Today, my name is Terry Fletcher. So today, I'm actually going to venture into something a little bit different. One question that's been popping up for me lately, with so many states opening up and more people getting vaccinated and more elective procedures finally getting back on the schedule, there will be a flood of surgeries to perform, and the hospitals may not be able to handle some of that capacity. So many providers have been looking into setting up either an OBL, which is an office-based lab, or an ASC with their partners, which is an Ambulatory Surgery Center. So I just wanted to discuss the topic in general terms before you dive in, but also to determine if this could be a way to make your providers aware of how to get back to a profitable practice after the year we've had. So I just want to kind of just bring some light into that area and see what you think, and hopefully you'll find some of the information helpful. I think I'm actually going to do a formal webinar on this in the next couple of months, so stay tuned and keep an eye on that. So today is the 177th episode of the Codecast podcast, and we are now at 206,000 listeners and downloads, so we appreciate that. The Codecast is also brought to you today by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. Okay, so let's take a look at this just from kind of the steps you want to think about. So first of all, what is an OBL? Okay, so the definition can vary by state, but in general terms, an OBL is an office-based setting where invasive diagnostic or surgical procedures are performed. So typically the term surgical or invasive, that's the classification you're looking for. They're classified by type and level of sedation or anesthesia required to perform the procedure. A lot of times the OBL, so the office-based lab, will be combined with the space designated as an ASC, Ambulatory Surgery Center. And the same space can be used separately for both on alternate days, but there's some state and insurance company requirements that you need to make sure that you are aware of. One of the things I would strongly recommend if you're looking to head into this type of thing would be to get a healthcare attorney who works with clients having OBLs. Make sure you have a CPA that's healthcare and also works with clients that have separate entities set up for this. And then also a consultant who works with clients that have set up OBL. So again, this is not to, well, I don't want to say it's not to generate business for me. I'm just saying that because we do that, but it's more just to give you some information if this is something you want to consider. So also when you choose the structure of the entity, this is where you want to be careful when you're dealing with advisors, because if you decide to create simply an office-based lab, so an OBL versus an ASC, you want to ask yourself some questions. So first, and this is really important because you're going to be dealing with some state and payer issues on this and regulatory requirements. First, will the OBL be used by only the providers in your practice, or will the OBL be used by other providers of the same specialty who are not part of your practice but perform services in your space? So there are regulatory and legal requirements for each scenario. And your healthcare attorney and CPA and your consultant is going to also have to look at the most favorable structure, because you're going to be dealing with an IRS situation. You might have to have a separate corporation or LLC, etc., and how to draft your distribution income formulas, because you also may have some issues when it comes to federal Stark and anti-kickback laws, and you definitely don't want that. So first of all, you're going to choose a structure of the entity. So if you decide to combine your OBL with an ASC, the rules do change. Again, your carefully chosen advisors can help you with this, but there is a navigation process. So just kind of as information, ASCs, so ambulatory surgery centers, typically require separate entrance areas, and this could be within your existing space, depending on design and varying by state. They also almost always require accreditation. I know I'm in California and we actually have that specific requirement. And this will vary by state to state and ensure what kind of accreditation and who the accreditation body is. ASCs typically also allow for more complex procedures to be performed with higher levels of anesthesia, which require recovering and monitoring areas, not just the area where the procedure is performed, like in an OBL. ASCs typically require higher levels of staff certification as well. You also need to have emergency equipment and transfer agreements in place with your local hospital that has to be within an 5 to 8 mile range to deal with emergencies. ASCs also, and this is the big difference, they can allow for billing of a facility fee in addition to the professional fee, the physician fee, depending upon the state and insurer involved, as opposed to an OBL where you're billing kind of a global service out of your office and not really a separate fee from the facility standpoint since it's in the office. Even if it's a separate entity, a lot of times it's just global. You want to investigate state requirements for the setup process, research specific limitations by state, and again, insurance. You want to make sure that you've got payers that are willing to add you as a provider. Make sure that you have a healthcare CPA performing what we call a pro forma. That means calculating the costs against the potential revenue, taking into account licensure and certification, what requires that, and the cost there. Construction, if any, if you're not leasing your building, staffing, equipment, supplies, and there's a lot of research involved. That's why I'm saying make sure you have some good staff to help you with this. And then you're going to begin research of insurers to ascertain things important to the financial success of either your office-based lab or your combination of both. Now, research the top insurers to determine a couple of things. First of all, will they pay for professional services provided in an OBL or OBL/ASC, or do they have a closed panel for facilities? Most physicians who are now coming into, new physicians, or they just licensed physicians, they can usually get on a panel for preferred providers, but facilities sometimes, especially if there are a few in close range, they sometimes close that panel. So you want to do your due diligence first instead of jump right in. Will they pay a facility fee in addition to professional services? And actually ask the question. Some will pay for a separate fee if you have a dedicated space in an office-based lab, but they will do it for an ASC. And then billing issues. So procedure codes that can be reported, what place of service must be indicated. And I found that interesting that is different from state to state. So we have certain, outpatient place of service. We actually have an office-based lab place of service that you can find in the inside cover of your CPT book. And then we have an ASC place of service. And you also, a big thing, and I kind of mentioned this when we also talked about telehealth, you want to research malpractice coverage. That is a huge deal. If it will be open to other providers, make sure you research the ramifications of your malpractice insurance for that facility. And if you're also going to use outside anesthesiologists that are not part of your group, because they wouldn't be covered under that umbrella. And so you just want to keep all of those business things in mind as you're thinking this process through. And then the final steps would be to proceed with accreditation and subsequent credentialing of your facility. So accreditation and then how the credentialing process works. You want to have operational policies and procedures required, as well as a corporate minutes. You want to prepare contracts with outside physicians. Make sure you use your healthcare attorney and CPA for that if it's an open facility, but you have to make sure your state allows for that. Sometimes they don't. And then arrange for any construction for entrance, for egress, or separate space for your OBL. That's really a big deal right now. And for those of you not familiar with the term egress, that just means a separate way to get out of the facility and a separate space. You want to then order supplies and equipment, and believe it or not, that's one of the last of the final steps. If you're going to use a billing company, make sure you're finding a billing company that has handled office-based lab billing in the past, and they have certified coders. And then at the last part of that, now you're going on as far as putting on your lab coat and getting your mask on and going to work. So there's a lot of steps that kind of are involved, and a lot of this that you have to keep in mind is the fact that this is a legal entity, and so especially if it's going to be a standalone service, You're entering into a partnership. You might have to deal with non-compete, and just really dealing with construction versus lease. And there's just a lot of information, state laws versus what federal will do. There's also something called hybrid entities that were required compliant contracts and structures. And because we've had such a change from the pandemic, where a lot of hospital procedures were allowed to extend to the ASCs, make sure you don't mix up what was okay or what is okay while we're still in the public health emergency versus what is legal once we get out of it. I know some things are going to kind of spill over as some of the rules that by the last administration and by Medicare was implemented as far as the global services that are now allowed to be done in ASCs. I think the new administration, they haven't really commented on it, but they didn't put them on hold. So I think they were kind of on the same page as far as allowing major surgery, a lot of them, there's a list, to still be continued in ASCs. But that doesn't mean that they'll be continued in office-based labs. Now, the biggest thing when you're choosing also a vendor or someone that is helping you to send up, that you want to make sure that they understand that there are basically three business models of the office-based lab. There's an office-based lab, there is an OBL and ASC, and believe it or not, there's a cardiology ASC, which is different and in different states. So cardiology has a completely different, I guess, model than any other specialty on that, because they're very unique to payer contracting and also what each state will allow and if the hospital has to part own it and things like that. And also because cardiology versus orthopedic, which is typically what you think of when you think of an ASC versus office-based lab, there's some issues when it comes to hemodynamic monitoring devices and really what you need to know as far as when you start to pick up this type of facility and be able to do it. One of the things that comes up, I noticed with some of my clients who we've set up and have this, is that they're trying to use place of service 24 for an office-based lab, which is not correct. Office-based lab is still going to look at place of service 11 as far as being office-based. And then I have some commercial plans that say, oh no, we want place of service 49 as an independent clinic, and then I even have others that say, no, we want place of service 81 as an independent lab. And so you just have to make sure that you're understanding what your payers are looking for so that you don't choose incorrect places of service. And you're going to have to deal with different entities, separate businesses, also tax ID issues. And so we just want to make sure that you're on the right track to start certain things. But here's the difference, and this is just what I wanted you to bring back to your physician. So a lot of my cardiologists have set this up. Obviously, some of my peripheral vascular physicians have really set this up. But let me just give you a kind of a snapshot of a reimbursement. Okay, so let's just say that your physician is cardiology and they do vascular procedures, so peripheral vascular. And let's say they do, FemPop, so femoral popliteal angioplasties in the hospital setting. Well, the average reimbursement for that, or I should say the allowable, is about $475 to do that in the hospital setting. So you're using place of service 22 or 21 if it's inpatient. So that would be the code 37224. Okay, so let's say that you now go to ASC and you're billing that, plus you're also the owner of the Ambulatory Surgery Center and it's allowed there. Now you get to add a facility fee of approximately, or you're going to get approximately $2,700. Now let's just say you're setting up an office-based lab. And so this is going to be in place of service 11 for an office-based lab for most payers. Your combined service, because you're not going to bill facility payment, would be $4,192. Let me say that again, $4,192, as opposed to just billing a professional payment from the hospital at $475. Okay, so let me just take it a step further. Let's say your physician did a femoral popliteal stent, so in the leg, and that would be code 37226. In the hospital setting, as a professional, just a provider, they would get $556 allowable. But let's say that you had an office-based lab, and this was something that, again, was accredited and approved, and a separate space. It has to be a separate space. How much do you think you would actually be allowed for that? Well, right now, the average for, again, place of service 11 to do the whole thing is $12,603. So just looking at the numbers, purely the numbers, the profits really kind of have to make you look and think about this. So you're looking at, maximum when it comes to peripheral vascular of maybe $800 as your allowable and reimbursed, but you're looking anywhere from $4,000 to $18,000 if you get into atherectomizing the vessels. So I don't actually recommend that. But if you're doing simple angioplasties, and I say simple because that's basically opening up that vessel and ballooning it and then it, being done with it. Or if you're just putting in a stent. Once you get into atherectomies, that's a little bit more invasive and a little bit, I don't want to say dangerous, but the accreditation process is a little different. But you're still looking at anything between $4,000 and $13,000 from a reimbursement perspective. And so it's really something your physician may want to take a look at, because it's 10% versus just, looking at the money at stake. And if you're trying to optimize reimbursement right now, it's really important to take a look at this. So really understand the difference, understand what your procedures are, understand what your legal liability, and understand what it takes to set it up. So typically when you're dealing with an ASC, you could be looking at 2 claims, so one for professional, one for technical, but the office-based lab is usually billed as a global service. Okay, so know what your software can handle as well, and understand what that means. And also, it's time to start negotiating with payers and carving out certain services if you have implantables, or if you have certain things where you have to track anesthesia, because those are extra. So anyway, there's just a lot of information when it comes to that, and I would strongly advise you to start talking to your physicians about looking at getting this possibly started or incorporating this into your practice. And if you need any help with that, you know where to come to, that we can help you with that, or at least direct you in the right place so that you have at least some, healthcare attorneys, healthcare CPAs, and professionals that can put you on the right track and start the process. It's worth it from a reimbursement perspective. Right now, the hospital's getting all the money. Why would you allow that? If you're doing procedures that can be approved for an office-based lab or an ASC, and you have the space, or your physician's willing to invest with partners, it's time to take a look at that. So I really wanted to bring that to you today. Okay, so let's talk about the coding question. And actually, my coding question is going to be in a couple of parts. So I'm going to do part 1 today. There's some FAQs, because I think I get a lot of questions on co-surgery billing. And I just want to make sure that today I'm going to give you the first factual information on that. And then next week, I will definitely expand further into the similar question. So it says, Terry, we are a general surgery practice, and many of our surgeries require the surgery to be done as co-surgery. How do I know if I can appropriately append the modifier 62 to my surgeon's claim? Okay, so first of all, check the medical documentation for several details. The first thing you want to do is you want to make sure that your surgeon worked together with another surgeon and that they were both considered primary surgeons. This is important because if your surgeon was a co-surgeon, then you can append the modifier 62. But if your surgeon was an assistant surgeon, then you have to look at modifier 80 instead. Once you've confirmed that your surgeon was indeed a primary co-surgeon and that it's allowed, also Medicare puts on a list, all you have to do is Google it, you must confirm that your surgeon worked together with the other surgeon to complete a procedure described by a single CPT code. What it says as far as, and I'm going to quote from CPT, when 2 surgeons work together as primary surgeons, performing distinct parts of a procedure, each surgeon should report his or her distinct operative work by adding the modifier 62 to the procedure. So for that procedure, as long as both surgeons continue to work together as primary surgeons, according to CPT, each surgeon should report the co-surgery ones using the same procedure code. And there's a lot more variables. We'll get into ICD-10, what that has to look like, and also looking at how to identify the other co-surgeon, and then making sure that if you're clear on some of the other indicators. But we'll follow that up next week. But just know that it doesn't apply to everything. A lot of things have to be either anterior and posterior, so front and back. It has to be a difficult procedure where it was absolutely necessary. And again, you want to make sure you're looking on that certain list that they put out with what will allow that 62 modifier. Our coding question today was brought to you by Keck Medicine of USC, over 500 nationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. Okay, so my personal tidbit this week is that my daughter gets to come out. Summer gets to come out for her spring break. And yes, she's had both of her vaccine shots. The second one gave her trouble. She did not feel well without that, but she's feeling better now. All good there. And I also get to meet again. I've met him once, her new boyfriend. So we get to go out for dinner, as many places in Southern California are finally opening up for inside dining as well. And it's funny, you never know what you've had until it's gone. I think we took it for granted, just the experience of going out to a restaurant. But we've missed it for a past year. My husband and I finally went out last weekend. We were sitting outside one of our local spots, and you just forget sometimes how nice it is just to have hot food that's not, delivered in styrofoam and to chat with your waiter. We're very friendly, and see other people enjoying themselves and laughing and just enjoy a date night out. I mean, when we were sitting there, we were actually looking up and there were stars in the sky. I know I'm being a little hokey here, but it was just really, really nice. So I hope some of you are getting to that point too, where you're getting out of the house and you're just able to experience just dining out. And believe me, the workers that are in the restaurants, they are really happy to see things opening up, because that's their livelihood as well. So we're happy to definitely get back to see them as well. So that's it for me this week. Make it a great day, and I will talk to you next week on the Codecast podcast. Thanks for joining me this week.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.